Welcome to the Learnskin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Our skin is our first line of defense, our largest organ, and a major component of our physical identity.
It plays an important role in our health, psychology, and how we connect and relate with those around us.
So join us as we delve into the art and science of skin health in today's episode. A short disclaimer before we get to the good stuff. Dr. Raja Sivamani and Dr. Hadar Levtov are board-certified dermatologists.
Yes, we are.
This podcast is meant for educational and informational purposes only. All opinions shared do not express the views of Learn Health, Inc. Neither this podcast nor any information contained within it are a substitute for professional care by a doctor or other qualified medical professional.
Absolutely not.
This podcast does not constitute medical or professional advice or services. If you have a medical concern, please consult with your physician.
Hey, Raja, how are you today?
Hey, Hadar, how are you?
I'm okay, a bit somber, These are some difficult times we're going through, but I must say those are not impossible times. We're all kind of trying to figure out how to go through the COVID-19 pandemic that is going around. But we wanted to do something for the population at large. So certainly within dermatology, one of the groups that is in need of careful attention are people with Hidradenitis Suppurativa, which in this program we'll refer to as HS for short. And this is why I'm very excited that we got a bunch of our people together. Some of our great colleagues from the HS Foundation has agreed to join us for this special podcast episode. So before we get to it, I just want to have a couple of things in mind as we go through this. The information that we provide here is really educational, and it's meant for doctors, but also patients may benefit from it. So it's okay if patients are listening. It's okay if you can't follow sometimes. That's okay. We'll try at the end to introduce some more patient-friendly questions and language, okay? And it's important to understand this is not meant as medical advice. Simply looking at some of the various questions that may come up as people are trying to manage a situation. And, we are going to discuss our approach, and different approaches will be considered here. You may choose one or the other, and that's okay. Because this time, these times that we live in right now, things are very, very fluid, and they change literally by the minute. So just remember that ultimately the decision to be made is together. It's a joint decision between the doctor and the patient, okay? So let's just jump into it. I want to introduce, because we have a large panel here, and I want to just say hello to everybody. Because everybody's CV is so big, I'm not going to go through it. We're just going to say hi and say where you're from, so people know. But we have with us around the virtual table here, Dr. Hamzavi, who's from Detroit, Dr. Joslyn Kirby from Hershey, Pennsylvania, Dr. Haley Nayak, who's from San Francisco, and Dr. Vivian Shee from Arizona. All of those are board-certified dermatologists. And then we have Dr. Stephanie Goldberg, who's from Virginia and a board-certified surgeon. We also have with us, which is great, Ms. Sandra Gilbo from Detroit, who's a passionate patient advocate. So we're glad to have you here with us. Okay. So before we get started, I just want to talk about COVID-19 and HS. I really want to give a shout out to the HS Foundation here. These are wonderful people, really give their lives to promote awareness and solutions for people with HS. So perhaps, Ilt, maybe you can start us off as the president of the foundation. Maybe you can describe the mission in a few words.
Sure. The HS Foundation is very thankful to Learnskin for this wonderful collaboration. The HS Foundation is a nonprofit organization improving the lives of people with HS through advocacy, education, and research. And our vision is a world where no one suffers from HS. And many of us, as you have described, have committed our lives to try to improve what is one of the most difficult diseases in our specialty. And during this difficult time of COVID-19, we don't want to forget what our patients are going through. So we thank you for this opportunity to discuss this condition and also inform our patients about how we can potentially help them during this period of time.
Excellent. So I think we got to get some facts straight. So we wanted to know what we currently understand about this disease. Jocelyn, you want to kick us off? Tell us, what is COVID-19? How's it different than the flu? I think initially people thought, it's just a little bad flu. So maybe you can start us off about that.
So a lot of names are being used for COVID, COVID-19, and coronavirus. I think a lot has been said about what is coronavirus? How is it the same or different from the flu? So looking back at just some of the information about these viruses, coronavirus is a large group of different viruses that can cause human disease. The flu is another virus that can also cause human disease, and both are RNA viruses rather than DNA viruses. But beyond this, their structures are not related. Both the flu and coronavirus primarily infect the lungs. What's different about coronavirus is that it seems to be a more severe illness. One of the first things that was found was the death rate was a lot higher with coronavirus, but from the places where we've had the most experience with coronavirus, the death rate is at least 10 times higher. And so that's why intervening on this disease to prevent and slow its spread is so crucial. Both the flu and coronavirus, again, primarily infect the lungs and cause more severe infections for people who have heart, lung, or kidney disease, or a history of cancer or going through cancer treatment. One of the other things that has come up most recently as we've been studying coronavirus is that it does occur naturally. Looking at the DNA of this virus evolved naturally and was not made. Both the flu and coronavirus, or COVID, enter our bodies through respiratory droplets, which are either breathed in or through touching things and getting it into our mouths, noses, or eyes, then get into our bodies. Most of the time, people experience a fever, shortness of breath, or cough. Very uncommonly, people may experience nausea, vomiting, diarrhea, or intestinal symptoms. This is not due to ingesting the virus, but is due to the virus being viremic, meaning it's in your blood and throughout your body, and is causing inflammation in the stomach lining. So I think this is important because it uncovers a few of the questions or myths that have been floating around. One is, while you may have similar symptoms and while it can infect the lungs like the flu, it does have a higher death rate. And the second one is that this is something that is getting into us through the openings in our mouths, nose, eyes, but is not through anything that we seem to ingest at this point.
Yeah, thank you. That was excellent. And a few things that are emerging, and again, this is kind of a fluid situation, but we know it can survive pretty long on surfaces, up to 72 hours on some surfaces. There's some evidence that it may enter the lining of the lungs and the alveoli through the ACE2 receptor. Now, it's unclear, though, if ACE inhibitors work or ARBs work. So just keep that in mind. We'll stay tuned for some more evidence. Now, we wanted to talk about, thanks, Joslyn, that was really good. And we wanted to talk about what are the implications for this, because we hear a lot about social distancing, and this has really transformed our lives in a really short period of time. So this is true for everybody, not just people with HS. Viv, you want to tell us a little bit about what is the reason for all this madness that's going around in our lives right now?
Thanks, Hadar. Madness is actually a pretty accurate word to describe this. Recently a lot of local governments has implemented and even mandated social distancing, but that's just to not interact with another human. But the advice is also to kind of shelter in place, right? Staying indoors if possible. I often tell my residents and students, and sometimes my family, this is actually called cocooning. So it's to kind of limit person-to-person exposure. From an infectious disease perspective, we know that COVID-19 is known to exist in the air in a room that houses an infected patient who's shedding for up to 8 hours. Its half-life is now known to be over 60 minutes. And we know that it could stay transmissible from an inanimate object for up to 3 days. So it's important for us to be, aware of these numbers as we are, practicing our social distancing and sheltering in. But from an epidemiologics perspective, we're still learning about the virus's transmission, how it goes from host to host, through respiratory secretions, object to host, and object to object. So while we know that many otherwise healthy individuals can be asymptomatic carriers and shedders, what that means is that they could be infected with COVID-19 and would have been tested positive, but they don't have flu-like symptoms such as fevers, sore throat, runny nose, and just feeling crappy, right? So since we aren't testing asymptomatic folks at this point, they can really transmit a disease to others who are at higher risk of developing severe symptoms, like what Dr. Kirby had mentioned, elderly patients who are immunosuppressed or have other, heart and lung diseases. So for that reason, it's really encouraged to avoid unnecessary social social interactions and try to stay indoors whenever possible to help us as a community to flatten the curve of COVID spread.
Thank you, Vivian. That was excellent. And one of the things that come up is a lot of times who's at risk, higher risk to get COVID-19. And I'm wondering, Haley, maybe you can take us through this because evidence clearly is still emerging, but there's some patterns that we've noticed from China and other countries and certainly now here in the U.S.
Yeah, thanks, Hadar. You're right. This is an ever-changing landscape, it seems, but based on worldwide data, we now know that all age groups can contract COVID-19, but we have good data from the CDC and other countries that show that the risk for serious disease and death from COVID-19 seems to be higher in older adults, and specifically those who are older than 60 years of age. This group of patients, particularly those with comorbidities, as Joslyn and Vivian have remarked on already, diabetes, heart disease, pulmonary disease, these are the patients that seem to be most severely affected. Now, we know that the mortality rate that we're seeing depends heavily upon the availability of optimal healthcare, and this disease has overwhelmed healthcare systems worldwide, and the lack of facilities, including ICU beds in many severely affected areas, probably contributes significantly to these high mortality rates. But what about folks under age 65? We know that mortality rates are lower in this group. An estimated 20% of all deaths that are occurring due to COVID-19 seem to occur in those who are age 20 to 64 years of age. And this age group, really, they can get sick. And while they tend to do quite well, this group specifically must remember that even if they aren't feeling so terrible, they can spread this disease, this virus, to others who are at higher risk of poor outcomes. What about children? What we do know is that children seem to do quite well, but the concern with children is that children seem to have particularly high rates of asymptomatic carriage. As high as 16% has been reported from groups in Wuhan, China. The one last point I want to make about children is that although children with COVID-19 have generally more mild disease than adults, there is one subset of children who can develop severe disease, and that is infants. We don't quite yet know why children with COVID-19 seem to fare better than adults. We think that it may be because of the relative immaturity of pulmonary receptors that the virus tends to enter the body through in the lungs. It may also be because children have higher levels of antibodies against coronaviruses and viruses more broadly, thanks to repeated viral exposures. Or they may have just different responses from their developing immune systems. But in infants in particular, they haven't had a chance to develop this immunity from exposures, and that's why we think that infants seem to do more poorly as compared with older children.
Yeah, that's a great silver lining, isn't it? Having kids at least safe. But one other paper I read about risk factors was about type A blood as a higher risk. I mean, we'll see how things transpire with more data coming through. But thank you for mentioning that asymptomatic carriers, because this is the real issue here. And I think we all have little brats around the house, and they tend to congregate and then stick to other adults and kind of spread the disease. So I think it's really I'm really happy you mentioned that, because you may think like you're feeling okay, you're feeling good, everybody's looking good in the family, let's go for a pizza. Well, no. All right, good. So thank you all. I think we kind of covered a lot of the basics, but Raja, why don't we talk a little bit about the implication for HS specific, right?
Well, I think really a lot of the questions that we're getting now is around treatment. And Haley, if you don't mind, I wanted to pick your brain a little bit more about how medication should be handled, because in this age of COVID-19, there's a lot of questions about, should I use my NSAIDs? What about biologics? Could you comment on that? How are you handling it? Any changes or any stoppages? What has been your approach?
Yeah, thanks, Raja. So in general, for HS patients who are well controlled and stable on a current treatment regimen, including regimens that involve immunomodulating agents, I personally favor continuing therapy, because what we don't want is to risk inciting disease flares that will lead patients with HS into healthcare facilities and all the associated exposures and risks that come along with that.
But yeah, that's kind of counterproductive, right?
Absolutely. Yeah, that is not what we want for this patient population. But along with staying on their current regimen, I do advise very strict protective measures for my patients on immunomodulating agents, including really diligent social isolation measures, as Vivian has already outlined for us, limiting unnecessary exposures, unnecessary outings, unnecessary visits to healthcare facilities, and certainly no elective travel. Patients should also be very diligent about hand hygiene and avoiding anyone who is ill. And then, of course, have a low threshold to hold medication and call your provider if you have a fever, cough, shortness of breath, or if you've had a known exposure to somebody with COVID-19. Raja, Hadar, you brought up an interesting point about NSAIDs that I think is important to touch on. So a lot of our HS patients take NSAIDs like ibuprofen, aspirin, other medications in this group for pain management. And there has been some evidence that shows that taking medications with anti-inflammatory properties, and particularly this group of anti-inflammatory medications, the NSAIDs, could worsen COVID-19 symptoms. But as of right now, and this again maybe is an area that is being developed and better understood, but as of right now, the WHO, the World Health Organization, says that there is not yet enough evidence to recommend against the use of NSAIDs. They do say, however, that if there's an option, acetaminophen may be safer to use than NSAIDs until we have more data.
Thank you for taking us through that. Maybe some of you have seen this, and actually we'll open it up to the group. There's been more and more talk about whether spironolactone increases ACE2 expression. I haven't really seen great data in that area. There was one study that looked at monocytes. Are any of you doing anything different with spironolactone if you are using spironolactone in your HS patients?
Right now, my approach has been mostly like Haley, keeping people on their medications and really making sure that, especially if they're stable, and making sure that they don't, end up in the ER. Spironolactone has been part of that for me.
This is Joslyn. I, like Hadar, was curious about the ACE2, the angiotensin converting enzyme 2. And the research that's happening now really is evolving pretty quickly. But it's important to note that we don't know how this protein and different levels of it may influence rates of infections or severity. We just know that this is the protein that the virus uses to enter the host cell. Beyond that, we really don't know much at all. So I agree and echo the comments earlier. If somebody's doing really well, then I'm encouraging them to stay on their medications. I want to keep them away from healthcare as much as possible and have them just continue to practice their really good sheltering or social distancing and, of course, hand hygiene.
Yeah, that is so true, actually, Jocelyn, and thanks for bringing it up, because we see in medicine a lot of times that over time, the data changes slowly, and then we look back, even 6 months later, and it's completely opposite. So we have to really be careful about what we recommend. Absolutely.
Yeah, and one of the questions now that we're speaking about medications, and now there's this huge run on hydroxychloroquine, thank goodness HS isn't dependent on hydroxychloroquine for treatment as a regular treatment approach. Although if any of you use it for that, please let us know. But going back to you, Joslyn, how do you address this question that even my patients have been asking me, because not all of them are aware of what businesses are open or not. The question is, will there be any issues getting my medication? Have you come across this question, or do you offer any words of reassurance to patients about this?
I think that it's a really reasonable concern for a lot of people who rely on medications to help them have quality of life. So I think that there's two things to think about when people have a question about getting their medicine. One is supply, and the second is, how do I actually get it in my hand? So to address the question of supply, the FDA is currently monitoring medication supply chains. And so when I was looking this up, I was really thinking very specifically about the medications used for HS, especially biologics, so injectable and infused medications. And again, the FDA is monitoring medication supply chains across the board, and so far there are no reported shortages of those medications. I live in Pennsylvania, so our state recently put restrictions on what businesses can run. This is happening in a lot of states, limiting which businesses are open and functioning. But drug manufacturing, drug delivery, pharmacies, these are all companies that are essential and are allowed to work. I think the other part of this is, okay, we know we have drugs, we know that we can get them from a pharmacy, but the second one is how to actually get them in your hands. So for a lot of these biologics, they go through a mail order or specialty pharmacy. So I think just keeping in touch with those pharmacies and having drug delivered is fantastic. I think trying to get into a pharmacy, walk in, pick up a prescription, I think that if it is possible to have it delivered to your house, if there is a way to call ahead to the pharmacy and have a friend to pick it up, I think, again, just keeping our people, our patients who have some conditions that, maybe would not be the best thing for them to be waiting in line at the pharmacy. Let's try and be creative and find a way to get their medications to them without that exposure.
Yeah, and I even heard anecdotally of people having patients waiting for their appointments in the car and then coming in one at a time for people who must see a physician. So people texting from the office to the cars. A lot of creativity is happening. Now, somebody mentioned staying away from people who are ill, and I thought they said ilt, but just want to make sure that people understand nobody needs to stay away from ilt. He's an awesome guy. And the next question goes to you, actually, Ilt.
And Hadar, get people off the beaches, my friend, out in South.
Oh, absolutely, yeah. In Miami, I got to tell you, in Miami, it's been really challenging. And, we have spring breakers here, which we love to have usually, but now is not a good time. So I think the cities have made strong statements and actually enforced curfews in some townships and so on. So yeah, absolutely. The beach seems like it's a safer place, but it really not. You really have to stay away from people. And it's very windy, by the way. So you sneeze and you can see when the droplets go, right? So Ilt, I wanted to ask you about this idea of social distancing, because our patients are slightly different in that they may experience a flare, even if they're well controlled, and we talked about that and maybe get back to biologics specifically in a minute. But what happens when somebody experiences a flare? How should they, maintain the social distancing guidelines under that circumstance? And that's true both for patients and doctors, right?
Right. Yeah, no, I think that's something that physicians and patients and their communities have to be practicing. And that's probably going to be the one big area that we can manage as far as exposing patients to other individuals, but also to each other. And so when you have a flare up, you have to, as much as possible, stay at home and stay away from the healthcare system. But I'm just going to walk through a couple of options. Then if you have to get in, manage that experience and minimize your risk. So as we spoke about Miami, if you want to come to the beaches of Michigan, I'm sure that would allow you to keep people off the beaches because it's 45 degrees here right now.
Oh my God.
But social distancing is something that you want to do in advance. Hand hygiene, we've all talked about that, but it's critical for HS patients, especially the patients who are on immunosuppression or immunomodulatory agents. Now, the question often with HS patients is, if I do get a flare, what do I do? And the first thing I would suggest to you is that, number one, establish your physician's hours right now, because a lot of us are going to lockdown mode. At Henry Ford Hospital and our private practices, we do have very specific openings. And in my particular schedule, I really only have openings for my HS patients and patients who have really emergent needs that could potentially burden the ERs. We will take them. But you want to check with your local dermatologist and make sure that you've got capacity to go in if needed. And you want to ask that question in advance. Now, locally, what can you do? You always want to make sure that you keep an eye on your basics of diet. You want to make sure that you're watching your mental health. And then you can do the warm compresses. You can also try items that aren't as well studied, but they're used. Topical resorcinol is often suggested. We'll often do a combination of topical antibiotics like clindamycin. They're not always effective, but there are things that you can do at home before you have to engage your physician. And if you do have a flare, do telehealth first. Let your physician take a look at the lesions, look at the distribution of the flare-up so they can get an assessment of where you stand, and then they can start prepping their own mind about how they're going to manage your condition. So those are some of the suggestions I have for my HS patients who are trying to anticipate a flare and trying to manage that. For providers, if I can go on there next, you want to look at a variety of disease combination agents. So as much as possible, you can use antibiotics for a short period of time. Clindamycin, rifampin are options. You want to use non-immunosuppressive agents, oral contraceptives, anti-androgens like spironolactone, finasteride are options. Retinoids are also options. Things that we don't always use, but things that we can consider that are not immunosuppressive. Antimetabolites are also a good option. Metformin is a medication that a lot of us use with HS patients that might help prevent flare-ups in advance of this happening. Now, if you still can't manage it, then you've got a couple of options, and that is you can start using some of the medications that have very limited data, but we're trying to use them in clinics. IL-12, 23 seems to have a little less immunosuppression than the TNF-alpha inhibitors, if that's where you have to switch off. And I think we'll talk about TNF-alpha inhibitors, which are still our mainstay in the biologic category. And we can also, if you want, talk about some of the IL-17, IL-23s. And then if you can get your laser, YAG laser procedures or laser hemal procedures, if you have that stage of HS, that'd be an option to kind of get done before we go into full lockdown, which is happening across the country. And lastly, if you really have to, we do use very, very short courses of low-dose steroids when people have a really bad flare-up. And again, we can do it. We would prefer strongly not to do it. But if we're going to do that, we want to make sure that you are in very strict isolation, very strict hygienic environments, and hopefully get through this.
Yeah, I agree. And thank you for mentioning that about steroids. And we'll touch about the biologics in a minute, because I think that's turning out to be the big questions for doctors. But you mentioned coming in for procedures, and we happen to have a surgeon on the show with us today. And I'm really happy that, Stephanie, that you joined us, because really some patients may have had a surgery scheduled and really are concerned about that. We know some patients, it's a great solution. So I'm sure there's a lot of anxiety, but maybe you can tell us how this has changed your practice in general, and then focus on HS and surgery.
Sure. Thank you for having me today. This is a really tough decision and a tough situation for patients to be in, because a lot of times it takes a lot of courage and a lot of time and thought to get to the decision of even having surgery. Right now, where we are with the COVID-19 is that most elective surgeries are actually being canceled right now. We have a big paradigm shift in the types of procedures that we're doing, and we're in a bit of a triage mode. I think in general, all elective surgeries for HS can and probably should wait. In my practice, we've actually canceled all elective procedures. I think the big thing and the challenge is trying to understand what's truly elective and what's not elective, meaning what can wait and what can't wait.
Right.
So it's very important that the decision for surgery be made in conjunction with your physician or your provider. And if there's any concern whatsoever, make sure that you try to arrange, if you can't get in to see them in person, either a telehealth visit or send a picture to your provider. They may be able to help guide you and keep you out of the emergency room or out of their office. In my mind, one of the only reasons to do surgery during this time would be if you have a true abscess, not an HS abscess per se, but a true large abscess, which has the potential to worsen. And again, that's hard for most people to differentiate. It's even hard for providers to differentiate. So please make sure to reach out to your physicians. The other issue that I think about is that by potentially going in for surgery and being in public, you're going to put yourself at risk to exposure of COVID-19 that you don't want to. And also, if there's a chance that to do surgery, they may have to put you under anesthesia and you have COVID but are not showing symptoms, this could potentially exacerbate your symptoms and make you sicker. So I really would recommend trying to avoid elective operations, and we'll try to get those done as soon as we can and as soon as it's safe to do so. If it's due enough already. Other reason is that you may not, to avoid surgery right now, is that you may not have the resources that you need to manage your postoperative wounds. So for example, you may need certain types of wound care or advanced wound care techniques or even home skilled nursing, and you may just not have access to that right now. So if you can hold off for right now and look for other ways to manage your HS, there are plenty of options out there.
Thanks for taking us through that, Stephanie, because this is a question that comes up frequently. And not only that, I was just off of a call with a group of dermatologists where we're talking about what does essential mean. And even that definition it can differ from dermatologist to dermatologist, and they don't have an official way of defining it. So it is really left up to kind of the scenario. I appreciate you taking us through that. Now, on that note, especially when we're thinking about immunosuppressives, I wanted to go to that next level and ask about the other immunosuppressives that people may be exposed to. And Vivian, can you talk a little bit about how you manage other immunosuppressives? Because as Ilt had alluded to, there's so many other biologics out there with, TNFs, IL-23, IL-17, and perhaps even other immunosuppressive agents that aren't one of those. So can you talk a little bit about that?
Yes, thanks for this question, Raja. So unlike, biologics or immunomodulators where they target a specific part of the immune cascade, at large, medications, when they're called immunosuppressives, they kind of they have a broader immunosuppression across multiple cytokine axes. Some of the ones that have been used in treating HS patients include, prednisone for flares. Other include methotrexate, or some individuals even cyclosporin. So because they're broadly immunosuppressive, there's a theoretically higher potential to increase our susceptibility getting the infection and have persistence and reactivation of the viral infection. So, when you wanted to consider stopping them if possible when the patient has viral symptoms, definitely, especially when they have had known or potential exposures to the virus. That's one thing to consider. It can lower the threshold to getting infected. But while the other way to look at it is in people who are kind of at the end stage of fighting the coronavirus, hopefully never a patient will be in that situation. The use of immunosuppressants, as seen from our colleagues' experience in Asia, may play a role in limiting the cytokine storm, which is the phenomenon that actually leads to acute respiratory distress syndrome, or ARDS, which is the main cause of mortality secondary to SARS and COVID virus infections. So at this point, we need more data to know how immunosuppressive really plays in the different stages of the coronavirus infection. So for my personal practice in patients, just like everybody else who's spoken earlier, if a patient is stable on their current regimen, I try to, as much as possible, to limit immunosuppressive use and keep them in their current regimen to give their immune system the best chance to combat COVID exposure. And personally, if a patient has a mild flare, I tend to choose more localized treatment and try to modulate their current regimens by adding or changing antibiotics without adding a immunosuppressive medication. So more data to come and more experience to be gained. And that's kind of the current landscape that we have in terms of immunosuppressive use in HS patients.
Yeah, it's definitely a complex landscape. So we appreciate you taking us through how you might approach that. Now, Stephanie had brought something up, which I think is really important to touch upon, which is, and I think several others had mentioned it too, is that now we're able to turn to telehealth a bit more. And I'm really curious, before we jump into any questions around this, could we just go around and just quickly tell us, are you using teledermatology as a way of seeing patients, and are you using them specifically for patients with HS as well? Can we start with you, Hadar, and maybe we can just go around?
Yeah, absolutely. So the University of Miami, as a policy, has been moving towards telehealth visits across the healthcare system. Our department has tried to be leaders in that sense, and I have scheduled patients for telehealth visits using our EMR system, and we are also improvising with some kind of on-the-fly type visits. So we're certainly moving, reduced almost, I think, below 10% our schedule now for in-person.
And then how about you, Haley, at UCSF? Are you guys doing a lot of telehealth now?
Yeah, so similar to the University of Miami, we too have transitioned most of our visits to telehealth visits. In my own personal practice with HS patients, I've tried to use a combination of live video visits as well as photographs and kind of store and forward type methods to take care of my established HS patients. For new patients who are new to me, this does present a challenge in terms of being able to see all the affected areas and properly examine HS patients. And this is something that we're really kind of trying to find creative ways to keep people healthy and safe and still be able to provide them the care that they need. But at this point in time, our approach has been to, as much as possible, transition in-person visits to video visits, telehealth visits.
And how about you, Joslyn?
Yes, we are starting a full telehealth service starting tomorrow, the 23rd, the last week. While the formal service wasn't up and going, we were doing a lot of over-the-phone discussions and counseling, which, to Haley's point, is a lot easier when you have seen someone before, is a little more challenging with somebody who's new. But I think the takeaway is HS is, I think, just as manageable through telehealth as it was in person. And for, I think, people who were concerned that it was going to be harder or difficult or not amenable, that's not the case. So let's lean into it.
Yeah, no, this is fantastic. Sounds like a lot of you are incorporating telehealth. How about yourself, Ilt? Are you guys doing a lot of it there?
Yeah, in both Henry Ford, which is a long history of telemedicine, as well as in our practice at Hamzavi Dermatology and Dermatology Specialists, we are fully telehealth. We're about 90 to 95% telehealth, and we have been able to manage our HS patients. So they just have to move the cameras to different locations. Obviously, it's a little uncomfortable or socially awkward in the beginning. And then we also ask them to palpate things. So we kind of give them measures of what do you expect this to feel like? Does it feel like some older fruit? Does it feel like a hard rubber ball? And then that way we have that tactile sense. Obviously, you can't get the same results as an exam, but you can get a very good idea of the distribution of disease, of how active the disease is, how much drainage is occurring. And when patients press down on lesions, you can also see how much fluid is coming out of those. And so we're getting quite a bit out of telemedicine. So I think that we can manage a lot of them with telehealth. Yeah, no, these are all fantastic points because I think it allows us to keep them from the emergency room. Vivian, are you guys doing it at University of Arizona as well?
Yeah, so we're also probably 90 to 95% telehealth starting this past week and probably even more starting next week. It's a unique situation to take care of HS patients through telehealth because we're essentially, changing the exam rooms into their bathrooms or offices. They typically need a more private area to do telehealth than other disease states, in my opinion. One thing I find kind of helpful is to have them dial in a few minutes earlier to give them the opportunity to kind of take off their dressings without having to rush into trying to show us the affected area, because that may cause a significant amount of pain. And it actually becomes a more intimate conversation in some way by just the one doctor and one patient without having sometimes learners in the room or supporting staff. So I actually the feedback I've gotten from my HS patient is that they actually prefer telehealth currently to have a more, a private conversation with their doctors and, taking away the need to travel a long way to see us because, travel can be painful and cumbersome for a lot of our HS patients. So far, still doing okay. Every day is a new day. Every patient's a new case. So we are learning day to day.
Yeah, and especially if they're immunosuppressed, obviously that makes their exposures much less too. And then Stephanie, you talked about telehealth. Do you utilize it quite a bit now as well?
I do. And actually, we've been using it for management of our postoperative patients for some time within our department. But over the last couple of weeks, we've actually now, for the most part, shut down our clinic and are doing all entirely telehealth. And I think this is something, as you can see, that's not specific to us. In fact, CMS and some of the other governing bodies loosened some of the requirements to allow easier access for patients to the telehealth platform. I think it's very doable, especially for patients who are being evaluated for possible surgery. It's probably even easier than the dermatologic evaluation to some extent by dermatologists. And even more so, the post-operative follow-up it's very easy to see how a wound is healing, what changes we need to make, whether it's done through a true telehealth virtual platform or through pictures that are sent through a secure link from the patients to the providers. I think the big thing is going to be making sure that all of our patients of all socioeconomic means have access to telehealth. And I think overall, this whole pandemic is going to change and expedite our use of telehealth in the future.
Well, I think it's clear just from this conversation that all of us have incorporated this, and probably this has been ushered in a bit more from the landscape of how we need to practice, just given what's going on. But let me ask a more pointed question, and I wanted to ask you, Haley, if there's a patient out there that says, I think I need to see a provider, and say, for example, their dermatologist is not accessible right away for one reason or another, if their practice was closed or it's not as easy for them to find them, what would you suggest that they do on how to go find someone? If they feel like they're in a flared state or whatnot, should they try to seek another telehealth source? Because, one question is, do I go to the emergency room or urgent care? Do you have any tips or anything that practitioners could advise their patients as they're talking to them?
Yeah, so I think really the guiding principle that many of us have echoed here today is that we want to do everything we can to keep our patients on immunomodulating agents and our patients more broadly, even those who aren't on immunomodulating agents, out of healthcare facilities. So as a patient, I think the first step really is to contact your provider either by phone or through a patient portal and let them know how you're feeling. And if that provider that you normally go to for HS care is your dermatologist and they're not available, I think going to a primary care physician or a surgeon, if a surgeon is primarily taking care of you or has been involved in your care, may be appropriate options. I think there are also other options like calling your local urgent care facility and talking with them about your symptoms and allowing them to help triage and determine whether or not it's appropriate for you to come in. Some symptoms, as I think we've all said previously here, can be assessed by phone or video visit, and this is now a very imperative way to limit patient exposure to healthcare facilities. And getting that guidance either from a provider or from urgent care facilities that may be able to help determine if a visit to the clinic or urgent care or your local emergency department is warranted is especially important now. For patients who are on immunomodulating medications, who develop fever, cough, runny nose, or simply just don't feel well, they don't feel like themselves, I think it's a good idea to reach out to your doctor sooner rather than later. And then last, and perhaps this should have been first, I think it's a good idea at this point in time, before people feel symptomatic, to reach out to their doctors and have a plan in place should you fall ill. What is the best way to contact your provider? What symptoms should warrant holding your medications? What are the office hours you can expect now from your provider? I think that planning, as Ilt mentioned, is very important, not just on the patient end, but also on the provider end, letting folks know when you're available, how best to contact you, what they should expect in terms of next steps should they feel ill.
Yes, and thank you for discussing that, Haley. And one of the questions that comes up is about people who are caregivers, like nurses or people who work in healthcare. How do you approach that when it comes to biologic? And I'm going to ask you, Haley, and maybe even then turn it to Joslyn afterwards.
Yeah, so I think there's no right approach. I think this is an area that's evolving, and we're still trying to figure out what the best approach for individuals working in high-risk fields might be in terms of helping them prophylax against infection transmission and how best to protect themselves. As we've already said, practicing good hand hygiene, reminding others around you to do the same is of paramount importance. For those working in high-risk fields, wearing the appropriate personal protective equipment is very important, and I understand that that is quite difficult now given the issues we have with PPE shortages. But as an aside, I think this is another reason why it's important that people with symptoms contact their providers before presenting to healthcare facilities, because every time a symptomatic individual goes to urgent care, goes to the emergency department, even if they don't have coronavirus, healthcare workers are using personal protective equipment that is then reducing the supply of PPE available to workers in our ICUs and hospitals taking care of COVID-19 patients.
Such a good point.
Hadar, yeah, so I think that's another kind of just a stewardship point that we all need to kind of keep in mind in terms of making ourselves available to our patients. But back to your original question, Hadar, I think, there's recent literature now that suggests that hydroxychloroquine, which is an antimalarial that's often used to treat patients with autoimmune diseases, as well as azithromycin, an antibiotic that we're all quite familiar with. These medications, when taken together, might be effective both for post-exposure prophylaxis as well as therapy of active COVID-19. I will say we should all keep in mind that this treatment regimen has not been verified in rigorous randomized controlled studies, but for healthcare workers dealing with highly contagious patients in a hospital ICU setting, there are some centers across the country that have suggested that using a combination of hydroxychloroquine with or without azithromycin indefinitely until this virus passes may be helpful. And there's also some data to support zinc supplementation as well as intranasal lubrication with just normal saline or Zicam intranasal spray to lubricate the nasal mucosa and try to minimize nasopharyngeal colonization in a manner that's similar to kind of the preventive measures that have been taken for influenza virus in this setting.
I think that a question that I've gotten from a number of people is I've heard that COVID can be more serious for people who have these comorbid conditions or a weakened immune system. And so I think the question has really come up is, if I have HS, is that me? And I think that the term weakened immune system or, immune suppression, these are pretty general terms that we toss around a lot. They generally just describe that our bodies can't fight off organisms quite as well. So it can happen for a lot of reasons. And we talked about how the flu and COVID we know are worse in people who are of older age, may have an underlying genetic disease or the chronic conditions we mentioned earlier. And people with HS, we didn't call out specifically, they may have one of these factors that's already been established, but not all people with HS have a weakened immune system. So I think it's just important to have that conversation as a provider with a patient, and as a patient, please reach out to your provider to help them clarify what your risk or health status is. So that way you can, decide what level of precaution you're going to take. So I think the main thing that a lot of people have talked about is if you're feeling sick, number one, stay home, isolate yourself and talk to your primary care provider or any provider as soon as you can. Masks are for people who are sick or people who are taking care of sick people, but it's not something that every single one of us should be using because it makes it less available for the people who are sick or taking care of sick people. The things that we can do, the CDC has a great website, cdc.gov, coronavirus 2019 NCOV. If you just look for CDC, you'll find it. Talks about how to protect yourself, which is really just, I remember hearing the first time, don't touch your face. And then that day realizing how many times I touch my face. And so just washing our hands, keeping our hands away from our face, using an alcohol hand sanitizer, 60%. There's some good recipes online about how to take 91% alcohol and make it yourself if you can't find hand sanitizer. And again, keeping your hands clean, keeping them away from the places where we could then get the virus into our bodies, staying away from people who might be sick or have had that contact. This is the whole reason behind social distancing. We just need to keep a little bit of room between ourselves and to recognize that if we're not feeling well, we really do need to just take that moment, take care of ourselves, get more information, and potentially not expose others.
Thank you, Joslyn, because I think you discussed one of the crucial points here. That is about HS. Is it a risk factor? And I kind of looked through the literature. There's been 4 sort of reports from China, epidemiological reports discussing risk factors. This is where we derive the kind of known risk factors we discussed earlier, like diabetes, et cetera. And none of them mentioned any skin disease. And I think it's important to reassure doctors and patients about that. And specifically, nobody mentioned HS. More than that, about the question of biologics, there was a report from a consortium of clinics in China that take care of 20,000 patients with inflammatory bowel disease. Now, different disease, but the medication profile they use is very similar to dermatology. And in that report, 20,000 patients across China, not just in the epicenter, but not a single case of COVID-19. And I couldn't believe it. So I actually emailed the director, I think he's the president of the organization there. And he said that's still true. And they have about over 50% of their people on biologics and immune suppressive like methotrexate and such. So I think it's important to keep in mind that what we talked about earlier, the data is emerging, but it seems to be okay to sort of keep the patients who are stable, be it a nurse, caregiver, or any other person, on the medication and then address it when it comes. And I think for both caregivers and patients, talk to your doctor. That approach is still true for the caregivers. Now, we mentioned telehealth, and I'm sure that some of the patients who may be listening to this say, well, I can't get a Kenalog injection through telehealth. So we'll get to that in a minute, but somebody may have a flare and need to go in. And I wanted to ask Stephanie, because one of the concerns that may be raised is how do we maintain sterility in that environment, and especially make sure that as we do the procedures, we don't get people infected, both the doctors and other support staff themselves. So, Stephanie, maybe you can quickly address that question.
Sure. I think it's a little different for patients and providers. If you're a patient and if you think you may have symptoms, it's important to call ahead and let the healthcare facility know that you may have it and really try to assess whether or not you need to be seen and if you need a procedure done. It may not be in your best interest and in the interest of others. If you do come, make sure that you maintain social distancing and make sure that when you speak to them on the phone ahead of time, they give you a protocol for what they would like for you. Similar to what I believe Joslyn said, we don't want to overutilize masks inappropriately because that will make it so that we don't have them available for providers when we actually need them. By the same token, we want to make sure that you are protected and that the staff is protected. At a very minimum, if you don't have any symptoms, maintain the social distancing. Most facilities now have a protocol in place to help protect you. Providers should make sure to wear gloves. And if there's any concern for anything being aerosolized, that would be the space where the N95 masks would come into play. But they're being regulated because we are running out, so they're not abundantly available.
Thank you. All right. So I want to switch to talking about patients because, folks, this is not an academic exercise here. We have a lot of professors, but we really want to get to hear the patient's voice sort of loud and clear. And, I don't know anybody better than Sandra to do this. She has really dedicated a significant portion of her time for patient advocacy. She's also an active part of the initiative, the Hope for HS. Some of us have chapters across the country. So, Sandra, I wanted to ask you, first of all, if you can tell us a bit about the Hope for HS initiative, because I think it may serve a great purpose in this time. But also, maybe you can introduce some of the questions that you think may come up for patients.
Thank you, Hadar. I think I just want to start by saying you're absolutely right that this is a useful time to talk about Hope for HS because our primary mission is to provide support for patients, and we do that primarily through in-person meetings, which are disrupted at this time, but we also have a large Facebook support group, which is where we field a lot of questions about COVID-19, and as we are all patients ourselves, we're not really qualified to answer them, but a lot of the questions that we have received so far have already been addressed by the doctors here. So I know that having this podcast available to patients will go a long way toward helping them feel a little more secure in this really uncertain time.
Thank you. And before you get to some of the patient questions, I wanted to say that initially we have a chapter in Miami, and, I'm one of those cynical guys thinking, oh my God, sharing and support group. But I got to tell you, I've been to a few of those, led some of those, and it is absolutely fantastic for everybody around. So if you're cynical listening to this, both doctors, providers, patients, don't hesitate. Go to one of the sessions. You don't have to say a word. Just be a fly on the wall and listen. I bet you will benefit. All right, Sandra, go for it.
So I think although it's already been addressed, it's worth reiterating because we get this question several times a day, is about the underlying health condition. So HS patients, I'm assuming that they don't also have the other comorbidities that we've already discussed, do they need to be worried about having a more severe case of COVID-19 or of being more susceptible to get infected in the first place.
So yeah, I think we've addressed that pretty extensively, but if anybody wants to add anything around the table, please free to jump in. I would say that one of the things you can do in the meantime, and I know it's easier said than done, is actually try to relax and increase your knowledge and focus on something active to do, like participating in Hope for HS, for example, because stress is going to make you flare, and you don't want to flare and then end up in the emergency room if you don't have to. So here's one advice.
And that's a great tip, because we get a lot of questions now even about the emergency room. There are a lot of patients that are managing their HS almost entirely through visits to the emergency department, and that has, for all of the variety of reasons that we've already discussed, to become a bad idea. So what are some of the alternatives to the ER, if there are any, if they're not already established with a dermatologist that's offering telehealth?
So I think we talked about using telehealth, which I think is really a crucial point. We discussed sort of how to go through an acute flare and trying to avoid the emergency room. But any other tips around the table?
This is Vivian Shi. This is a great question about the ER. I think many of my patients prior to coming in regularly in HS specialty clinic was using high cost settings or urgent settings as their primary mode of HS care. And with the current work that we're doing with the HS Foundation and with Hope for HS, we hope to change that. And I think more than ever now is during the special time that, where resources are limited, is education on both parts, patients educating doctors and doctors educating patients to kind of empower them during this special circumstance. So some of us are working together on this project called the HS Action Plan. And Dr. Kirby and Dr. Hamzavi have heard about this thing that we're doing, where we are educating patients as through a shared decision platform on coming up with algorithms of what to do when patients have a mild, moderate to severe flare. So patients are empowered to kind of manage their HS at home and have instructions on when things, what are the criteria that we need to call the doctor to come into the office, and what are the ultimate criteria when all fails to ultimately go to the emergency setting. So I think hoping to work towards this in the near future to come up with a plan to minimize ED exposure while still being able to manage HS flares with our patients through telehealth and some in-office visits.
I just want to jump in for a second. This is Joslyn. And to say that telehealth is not something that's just happening in academic centers. A lot of dermatologists in community health settings are getting their own telederm practices up and going. So if someone is out there and their dermatologist is part of a smaller group in their community, please don't assume that they're not going to have it, because it is happening. It's happening in a lot of different practices. The second thing is now, because telederm can be a more efficient visit, if you haven't seen a dermatologist before, try and get in with one, have one of those telehealth visits, because going to an emergency department, if that was your usual mode of operation, don't do it. It's risky for you. They're focusing on some pretty dangerous things. So get in with the dermatologist, establish a relationship now through telehealth, and that way you'll be able to keep it going with them after everything is a little quieter.
I'll jump in here as well. One of the challenges I think that patients will face is when they're on Medicaid or Medi-Cal, because there are just not as many dermatologists that take them. Our practice is, I have a joint appointment at the university, but we run a private practice, and we're 70% Medi-Cal right now, which is the Medicaid within California. So, we've stayed open just for this reason. If there are challenges, and now they've relaxed regulations to go across state lines. I don't know how that works for Medicaid patients, but do any of you have any suggestions for that specific patient population group? What would be their next mode of action if they don't have a dermatologist that's easily accessible? Do you have any suggestions for them? Should they try to go to an urgent care locally instead of an emergency room? What would be their options?
So if I could add something here. In general, we have a very large Medicaid population at Henry Ford. We also take some of those patients in our private practice. So an academic center is a good place to start off and see if you're close to one. But given the fact that telemedicine reaches across a large geographic area, it's something that within your state you can do. So if you contact your Medicaid carrier or the specific one in your state, you may want to see what dermatologists are listed, try to find an academic center, because many of the times they have specialized contracts that allow them to take those patients. And now with telehealth, they can actually access them even if they're 200, 300 miles away from them. So that might be a first starting point. And then for procedures or specific events, the academic center, and we're doing that right now, can actually work with small rural Michigan is what we're doing right now. We can indicate to the surgeons or the providers, we've got a HS flare up. We don't think we can manage it medically. We need you to excise this area. This is what you have to do. They're more than happy to work through that as long as we give them clear directions. So I think that might be an option this period of time.
That's a great strategy and discussion. Thank you. I'm going to go back to Sandra because I think you have a few more questions for us, right?
Yeah, thank you, Hadar. So we've talked a lot about biologics, and it's been really educational for myself, and I'm sure any other patient that would be listening right now. But a couple of things that we maybe have not discussed is there are patients out there that have either started the process or are considering starting the process to start a biologic for their hidradenitis suppurativa. They're now considering postponing those first treatments. Is that something that you would recommend for patients during this outbreak?
Hey, Joslyn, you want to take this one?
Sure.
Do you start patients on biologics now?
So I've had a couple of patients who started just as coronavirus was really starting to make a dent here in Pennsylvania. And for the couple of patients who did start, we started that medication because their HS was very severe. And so the conversation that the patient, the family, and myself had was, do you feel comfortable? Can you protect yourself? If necessary, can you isolate yourself or shelter in place? Because they were worried about that exposure and the chance of getting coronavirus. They felt like it was something they could do, that the HS was, number one, so impactful, and number two, they thought that they could do the protective measures. I think for people where the burden of HS may not make that decision quite as clear, then it's important to have the conversation with your provider about whether it's worth medication or getting to a place where mentally, physically, immunologically, everybody feels a little more comfortable in 2 weeks, 4 weeks, or 2 months.
Excellent. Any other comments about starting a biologic right now?
This is Haley. I guess I'd just echo some of what Joslyn was saying, which is that there isn't really a one-size-fits-all approach to this. And for folks whose disease is severe enough that they require biologics, some of the factors that play into whether or not you start a biologic in this very challenging and unusual time includes kind of where you are in the country, what the status of COVID-19 is, where you're at, and as Joslyn said, how, or rather what your capabilities are in terms of being able to protect yourself and socially isolate. So I think the most important thing is really to reach out to the prescribing provider and have an honest conversation about what the risks are, what your ability to protect yourself is, and kind of make the decision together.
Yeah, if I could add to that, and just to kind of make maybe a hardline statement, I just feel that starting a biologic when you've got a couple of risk factors, one is age, above the age of 65, once you have another chronic disease state, chronic diabetes is not well controlled, another inflammatory state, heart disease, I think in those areas you have to be very careful of starting a biologic at this time. Outside of that, I think it's kind of up to the provider, but once you're getting into those comorbidities, I'm not sure if it's the best thing to do at this moment.
This is Vivian. I think the other one thing to think about is the biologics don't work really fast. It's not like we get our loading dose today and by, a couple days or a week from now, we will be in clearance. So the pharmacology of the medicine is that it may take weeks, if not months, to reach the optimal clinical efficacy. And whether the clinical efficacy, really, mirrors the risk for potential infections or immunomodulation remains unknown. So just like what the other providers mentioned, it really has to be a case to case decision, taking into consideration that if the disease is not well controlled and if a biologic is not started, there may be reasons, we may run into a situation where other healthcare resources may not be available to help the patients go through and deal with the flare otherwise.
Excellent comments. Thank you, everybody. Sandra, you had a question, something about Hibiclins, didn't you?
In the news, everybody has seen that there's been a run on toilet paper and hand sanitizer, but we're actually getting reports in our support group of people having trouble finding Hibiclins when they need it to manage their HS. Is there anything that they can use over the counter or otherwise to get them through until it's back on the shelves?
Ilt, you want to take this one?
Specifically, I think that you have a couple of options. One is you can do the home remedy, which is basically taking very dilute bleach solution. So a quarter cap, not a cup, a cap of bleach in a half tub of water and swirling it around. You can soak in that. That's one option. There's also specific hypochloric acid derivatives. There's a brand, I think, Clear, that's available on Amazon that you can also use as kind of a disinfectant. And then straight benzoyl peroxide, which is something that you can also find in the acne aisle. A lot of kids are maybe stocking up on benzoyl peroxides, but that's another particular agent that you can potentially use. So you can do homemade recipes. And our family, we just got bleach because Clorox wipes are all out of the stores right now, along with toilet paper. I don't know why those are connected, but that's for another cultural conversation. In addition to the hometown remedy or the homemade remedies, you can use the bleach option. That's probably your cheapest bet to go. And a lot of people are just making up the solution, storing it, and they can use it when they have a flare-up.
And one of the things I tell patients is that you can use antimicrobial soaps as well. One comment, though, is keep it to the affected areas. You don't want to strip your skin from its natural protection elsewhere. So you get dry skin and start being itchy and such, so leading to other issues. So antimicrobial soap over the counter like Dial, Lever 2000, those are decent options.
I also recommend benzoyl peroxide wash for my patients, again, limited to the affected areas and kind of leaving it on the skin for a few minutes before washing it off in the shower. And that seems to help folks quite a bit as well. And that's also available over the counter.
All right. I think we gave a bunch of options here. Thank you, team. Sandra, you had a couple more questions, right?
Yeah, just a couple more. Thanks for your patience. So another question that we've gotten about biologics, even though they've been told by their provider to stay on it, have some issues, some fears that if we could address, people are wondering if there are risks to stopping a biologic, skipping some doses, and going back onto it when all of this has blown over.
I can get started. Maybe Joslyn, you can jump in as well. So in some of the biologics, there is evidence that you can develop antibodies if you stop it. And then the recapture rate, meaning getting people back to the same level of efficacy once you restart it, is reduced. So certainly there's a problem there. The other issue that we talked about is the fact that you may end up with disease flare if you stop the medication. And so you end up having to go to the emergency room, which is a much, much higher risk at this time right now. So I think this goes back to the approach that we said before, is that in general, if you're stable and you're doing well, we're going to probably recommend that you continue taking the biologic, but at the same time, you practice all this good stuff we mentioned about social distancing, et cetera. Joslyn, you want to add anything?
It's hard to add anything. I think you covered really important things. I would just echo what Vivian said earlier, which is you might skip a week, but the medicine is still in your system. And so if your concern is wanting to turn off the biologic because of COVID, it doesn't unfortunately go away that quickly. So you still have to do those protective measures because the biologics have a very long period of time that they last in the body. Stopping the biologic doesn't take away the risk right away, so continue to practice good protective behaviors.
All right, Sandra, one or two more questions so we can wrap up.
So another question that we've gotten from HS patients is regarding disability pay short-term being offered.
Oh, that's a good one, yeah.
Yeah, so patients want to know if they qualify. It's often because it's for people that are at higher risk, and listed is whether they have an autoimmune disease or not. But there is a lot of confusion. Is HS an autoimmune disease?
Viv, you want to take this one?
HS is closely associated with a number of other autoimmune diseases like pyogenic gangrenosum and a lot of rheumatologic diseases. I have personally had some success helping patients obtain disability for very severe HS that will interfere with their career and school productivity. But I've also had challenges where employers and various agencies have not listed HS as one of the autoimmune diseases and comorbidities. So we're still fighting the fight. And the success I've had is actually, helping them fill out the form in the office as much as we can. And also with the patient's permission, submitting a progress note and even a letter from the doctor's office. Also attaching any literature available to support the burden and the severity that HS may have, and the impact that HS may have on our patients' daily life and job performance. So that's kind of what we've been doing in our office. I'm looking forward to hearing what other people has had success in.
Yeah, and I just want to say that strictly by the definition, HS has not yet reached the definition of autoimmune per se. There has a few checkboxes it needs to check. Who knows, maybe in the future. But in my experience, my HS patients have a ton of other reasons to get disability if they really need it. Not just the nature of the disease, but really the actual, meaning by the pathology, but actually the actual disability that you suffer from by having the disease active. So I think there's a work that you have to lose and so many other comorbidity associated with that to me it's never been an issue about defining it as an autoimmune disease. Rather, it's talking about, hey, this person cannot walk, this person has constant pain, this patient has constant drainage. And when you list that, usually that should be sufficient to meet criteria for disability if the patient truly is there. Any other comments around the table about disability?
Well, I did want to have one more comment on this, because I have a couple of patients that are remote and they work like they're 250 miles away. And, they called in and said, hey, and they're well controlled on biologics. It's not really, COVID-19 isn't that prevalent yet, but they're in a position where they're in a county system and they're seeing a lot of people in their job where they have to keep talking to new people. They're interfacing into the general public. They're not at a desk job. And I just want to clarify with HS, this whole autoinflammatory versus autoimmune, if someone can comment on that, that'd be great. But suffice it to say that I did write a supportive letter saying that she's already immunosuppressed. It's probably not a great idea. Even if the burden is not that high, she's going to be talking to hundreds of people, just interfacing as part of a position that she needs to be in a position where, and the company said, we'll give you disability if your doctor says this isn't a good position to have you in. So I wrote the letter and they said that's fine. And they allowed her to go on disability from that. So just one anecdote of someone that wasn't flaring quite yet, but was in a situation where probably wouldn't have been safe.
Yeah, excellent. And that goes again to that same principle. I wouldn't stress too much for the patients listening about the definition of autoimmune, because really disability is about the practicality of life. So as Roger gave a great example there. All right, Sandra, one last question you have for us?
Yeah, so one last question that we've gotten. There's been a lot in the news about the quote unquote cytokine storm in patients with severe COVID disease, and that there's been some use of biologics to treat it. And so people are wondering if these are similar at all to the biologics that they may be on for HS.
So in treatment protocols that I've seen, the only medication that would qualify as a biologic that is introduced is anti-IL-6, which is not the typical biologic that we use in HS. Probably the answer is they are similar in mechanism, but they're not really attacking, in the idea that they're antibodies, but they're not really attacking the same pathway that HS's medications attack. At the same time, and that goes back to the question, do we stop biologics or not? We don't know. And some people have proposed in a theoretical manner that actually maybe being on a biologic may help because it kind of modulates the immune system to where it needs to be. So during that cytokine storm. So we don't know yet, but strictly speaking, those are not the same medications. Any other comments on this?
This is Vivian. So just looking at the Chinese experience from previous SARS and the current COVID saga, the cytokine storm is a really result of, mainly T cell and B cell activation and releasing a massive load of immune mediators, like I said earlier, ultimately causing ARDS. So far we know that the cytokine storm components include IL-6, like what Hadar had mentioned. Other cytokines include IL-1 and IL-18 and interferon gamma. Among these four, the only drug that's not remotely, but has been used to treat HS and has a target in cytokine storm is interleukin-1. There's a medication called anakinra, which kind of targets its receptor. But we have to really keep in mind, I think, that by the time a patient has cytokine storm, we're looking about life-saving measures rather than, kind of worrying about the effect of a biologic in terms of increasing the susceptibility to exposure and initial infection. So I think it's important for us to make that distinction. Cytokine storm is something that happens in really critical disease states in the setting of COVID-19.
Well, thank you, Vivian. And I want to thank everybody. I think we had such a long, extensive discussion that really touched on a multitude of issues, both from a patient point of view and from a doctor's point of view. We're going to try to have this podcast episode released to the public at large through the HS Foundation, which is doing an amazing work, maybe the Hope for HS network as well, and also through the Learnskin network. So I want to thank everybody around the table here, the virtual table, who are very much practicing social distancing from across the country, literally. Thank you for your expertise. Thank you for your time. And thank you for caring for these patients.
Yes, thank you all.
Thank you
for organizing this.
Thank you.
Thank you.
Thank you for tuning in to today's episode with Dr. Raja and me, Dr. Hadar. This podcast is brought to you by Learnskin, leaders in integrative dermatology education. Visit learnskin.com/podcast to explore our many programs or subscribe to the podcast today and never miss an episode. Have a great day and stay curious.